Sisi tunatoa watoto, tunawapatia. And then they take it from there. Dr. Laura Oyengo, consultant obstetrician. Honorary. Consultant pediatrician, working with UNICEF, a very good friend of mothers and, of course, babies. That one comes without saying. So Dr. Laura Oyengo will be chairing this afternoon session. All yours.
Good afternoon, everyone. Where are the rest? Call a friend to call a friend to call a friend. They are still eating, eh? Even with the eagles. So this afternoon session, we are now going to actual implementation. We are going to hear about activities and projects that have been done and what that result was. But to start us off, we have a speaker called Dr. Engelbert Bain, who is a global health physician, an implementation research scientist, and an empirical bioethicist. Mumesikia hiyo? What is an empirical bioethicist, anyone? We can Google. Dr. Engelbert operates at the highest level of strategy, policy, and influence, currently serving as the implementation research scientist and the deputy director of the Masters in Science program in Global Women's Health at the University of Oxford. Not the University of Nairobi, but sasa huyu ameenda juu kidogo ako kwa University ya Oxford. He drives transformative agenda in equity, health politics, and diplomacy. And he also looks at decolonization of global health. He has over 17 years of experience. He has advised leading global institutions, including WHO, UNFPA, and IPPF. His work sits at the intersection of evidence, power, and execution, supporting governments, funders, and institutions to design, position, and deliver high-impact, scalable solutions in complex global health environment. Ladies and gentlemen, I think we are going virtually, and let's welcome Dr. Engelbert. Makofi kwake as he comes. Oh, you are here? I thought you were jetting in. Karibu sana.
To the best of my knowledge, I thought I had sent my presentation. Dr. Wanji. Anyway, as we wait for the presentation, no, thanks so much for the very generous introduction. Check on email. I sent to the email. Info somebody. No, it's not. I can see. Can I use my laptop?
Yeah.
But how am I going to project?
I'll use this one.
Okay.
Yeah.
Is it working? Is it connected to?
Yeah.
I sent it an email.
It's okay.
It's okay like that?
Yeah.
Okay. So once again, thanks for the very generous introduction. I can imagine that we are already not doing very good on time. So I have two conflicts of interest to declare. The first is that I don't have very nice slides like Prof. Bimbo, and the second is that I don't have a very structured presentation. If at the end of this discussion we have a lot of questions to answer, then answers given, then I would have achieved my goals. So if you are very structured and very story, you need to get some paracetamol because I'm going to do some harm to your brain. So a couple of questions to start with. Everything that we are doing, everybody talks about impact. But what is impact? And I would say what is impact in global health research. I had the good fortune to participate in the recent, its Essence is called Essence, which brings together global health research funders in Brussels. Gates Foundation has a completely different definition for impact, the welcome, different. We don't have any common definition for impact. If we ask the researchers that we have in the room and the implementers that we have in the room, what is impact, you are going to have completely different definitions. But it doesn't mean that there are no common areas where we can agree, we can have a bit of consensus. But I think this is a fundamental question and a fundamental challenge for us. If why we exist and why drives what we are doing is impact, and we have no idea of what impact is, we cannot communicate impact. It means researchers cannot properly factor in impact in framing their research questions. It simply means we cannot monitor impact. In fact, that we are lost. Then I think that is where we should start from. And we have a lot of organizations, not excluding the University of Oxford and University of Nairobi, that attract a lot of grants. Very good at attracting lots of grants, very good at executing lots of grants, but maybe I'll disappoint you that it's not because you are good at attracting grants, it's not good because you are good at executing grants that you are creating any impact. You might just be good at the business of attracting grants and just good at the business of executing grants. This is just a forum, just placing our minds to rethink whether what we are actually doing is impactful or meaningful. And I think it's a continuous question that we need to ask ourselves with the work we do, most importantly, when it comes to maternal and child health. So we are currently leading quite some work now on actually coming up with a global health research impact scale that is going to allow for communication amongst funders, because funders now are putting their heads together to fund common projects that is going to permit researchers to frame research questions through that specific scale, so that if we fund what is impactful and we frame our research questions through what is impactful, we can easily communicate and have like some areas of commonalities so that we know exactly that we are doing the same thing. I was tasked to talk around research mobilization but I strategic communication, I have argued that, to me, it's a strategic and ethical process of translating, sharing, and exchanging scientific knowledge with diverse audience through the right people, the right formats, the right channels to build trust, inform decisions, inspire innovation, influence policy and practice, and maximize societal impact for research. I highlight intentionally strategic and ethical. Strategic because it's not an ad hoc kind of thing. But ethical because most of the research that we do It's funded by taxpayers' money. We have human beings that offer their bodies and their time. So they deserve to have the outputs, what happens with this research. It's not a favor that scientists are doing to the public to communicate science. It's an ethical imperative. It's an ethical mandate. So investing in science communication is an ethical mandate. And we all agree that we have not, and we are currently not doing a good job when it comes to that. I will disappoint my fellow professors in the room. So, just as a continuation that the work that you do, or in fact, if you publish in the Lancet or in, I don't know, in Nature, how many people are going to read? Nobody reads. A few people do, I know you do, but a few people read what you publish in those spaces. It only makes sense or create impact after you have published in those places. What do you do with what you have published in those places? From what you have published in those places? Real people live in communities. Real people live in marketplaces. But real people today live on social media platforms. Real people are on LinkedIn. They are on Instagram. They are on Twitter. That is where real people live. If you ignore those spaces, you don't know exactly what you are doing. And I've argued also that we are living in an age of what I've called scholarly pollution and scholarly constipation. Scholarly pollution simply means with the numerous predator journals, with the pressure that these professors are putting on younger faculties to publish and change grade, we have a lot of bad information. A lot of bad information that is polluting the scientific space. If you look at the progression in the data, if you just take BMC journal series, the progression in the past 5 years, the number of journals have increased by 246%. We also have a lot of good information. So that's what I've called information constipation. So it's a double edge. We have a lot of bad information, and we have a lot of good information. So you need to be intentional and strategic when it comes to communicating, not only for communicating's sake, but communicating for impact. Maybe some of the seniors or the CEOs that we have in the room have always taken investment in communications or strategic communications as a burden, but it's a strategic investment for any organization. It attracts funding. Don't always look at what is happening in the now. Look at what can happen in the next 2, 3, 4, 5 years. Helps in influencing policy. Some partners are only going to come because they've seen what you have published on your website. It increases research uptake if it is good research. Strengthens institutional reputation. People are not going to come into your mind to know that your institution is good. Nobody has time for that. And you makes your information to become a thought leader. Maybe just a conflict of interest. I don't have anything to do with the Conversation Africa. If I publish in the Lancet, I don't know how many people are going to read. But if you repurpose and put across in the Conversation Africa, be sure that 30 to 50 million people are going to see it. And for some of you who are experienced, you are going to see that most of the reactions or the impact that you get from the papers that you publish come most of the time from repurposed publications, because that's where real people are. They don't have time. So I think this is still very important, and I'm insisting on this, that scientists have an ethical responsibility not only to generate evidence, but also to ensure that it is communicated in ways that enable people to understand it, trust it, and act on it. The boss, the society, deserves to know what it funds. And it becomes really very critical to equip every researcher to become an effective communicator. I know we just ate. Can we just stand for 1 minute, please? I'm seeing a couple of people sleeping. So in 60 seconds, just do what I do. Then you grow up, down, up, down. Then you go to the right, back. Then you go to the left, back. Okay. So you can see. Let's get into real business now. I think it's worth repeating that your work does not speak for itself. I will repeat that. And that I'm happy that we have a lot of senior people here. Science communication is not a soft skill. Budget for it and teach people how to communicate. Science communication should not be an afterthought when you have already won the project and say, no, integrate science communication as a work package as you write your proposals. And as a former funder, I can tell you for free, they might not tell you if you have a better science communication strategy, you stand out amongst others. They will not tell you, Okay. The fourth myth is around networking. We try to network as something that is supposed to be convenient. I've put another slide just on networking. Because one of the failures that in my view, that I see is that we take a lot of things for granted. We assume a lot. So you think, if I can just, how many people were taught how to prepare to attend a conference? How do you prepare to attend a conference? You find that you might have attended 50 conferences and it was a complete waste of time. You are supposed to be taught how to attend a conference. I can take 2 minutes and I teach you how to attend a conference. Okay. If I want to attend a conference, imagine I'm coming to this conference, I target only 2 people, maximum 3. Let me play with you, Professor Bimbo. What I do is I go to your publications, I go to your 10 top publications, most cited publications, and I use ChatGPT and it gives me a key message. I go to your 10 most recent publications and I go to the limitation sections. It gives me a clear direction of your research gaps. I go on Google and I Google everywhere you have traveled, where you have studied, the people that you have visited, and I identify areas of commonality. You give me 90 seconds, I kill you. You understand? That's it. So attending a conference, identify the people. AI is there to help you just so that when you start with the person, you say, I was here, I studied here, hey, I read this, your most important paper. You say, okay, my work now, this is the direction. You are getting into the person who does not like to be cited, who does not like to be read, who does not like to connect, But these are things that you consider that are small. You go, you collect, oh my God, I have business cards like this. That's a complete waste of time. So there are other things when it comes to preparing to attend meetings, preparing to attend conferences. Because these are strategic investments for organizations, and people should not just attend those things in any kind of disorder. So these are things that are supposed to be taught. You are going to see now with what is happening with the workspace, a lot of people are losing jobs whatsoever, and you're going to say, okay, the right attitude is going to allow you where people are going to put your name to the table when you're not there. What does it mean to have a right attitude? I just got a master's of public health from Amref University International. What is the right attitude? What does that mean to me? So we take a lot of things for granted. A lot of things have to be taught. And you're going to see that all of these are very important when it comes to the resource mobilization ecosystem. Because you have the people you are meeting from Gateswell, those are human beings. You are talking to human beings. They are real human beings. And you are supposed to prepare to meet them. We have we need to move from making diagnosis to actually providing solutions. And one of the things, or one of the areas where we have overdiagnosed is that what? To match the challenge that we have now, we need local resource mobilization. What does that mean? How can we, or how should we, or what are the best practices in unlocking resources locally? Those are the important questions that we're supposed to be asking. And maybe we could start with spending a bit of time. If I want some money from Safaricom Foundation, I don't just get up and I go and start talking to them. No, it doesn't work like that. Spending a bit of time to look at their motivations, look at the organization's corporate social responsibility, look at their past strategic plan, look at their current strategic plan. Know exactly what they want. If I want the government to invest in what I'm doing, if I want to meet the PS, I'm aligning, my message should align with national priorities. And we need to teach people. I think Professor Bimbo actually spoke a bit on this, on what it means by long-term partnerships rather than one-off grants. And I can tell you this is important. A relationship that you develop today might be useful for you in the next 3-4 years. The most important lesson that I learned in primary school arithmetic is compound interest. Things compound. Don't expect things to happen overnight. Things compound. If you have that kind of mindset, you are going to be intentional in building relationships. You are going to be intentional in building your networks. And everybody meets everybody all the time, most importantly within the health or global health space. So don't always think in terms of now I want a grant in the next 6-7. That is not going to ever happen. So I think just a continuation, because all of us are saying that we need to unlock funding locally. And it's important for us to understand the psychology of the philanthropy, their motivations, relationships, and you're going to understand a bit why it's really important to understand relationships, stewardships, trust building, and long-term engagement. Okay, I think this is the most important part. Everything is political. Even your life is political. Everything is around a game of interest. We need to appreciate that reality, and it has been increasingly we are taught social determinants of health, political determinants of health. But the disappointment is, why are we not teaching? Because at the end, it's the policy maker, it's the politician. Why are you not teaching people health politics as a discipline? Health policy, useless. Public health, useless. Global health, useless. It's only health politics that exists, because that's really just that's what exists. So appreciating that everything is political is critical. Let's take the first level. Don't think that it's because somebody is the PS or the CS that he is the most influential person. Big mistake. You have a lot of people that are lower in the ladder, people that have nothing to do with the Ministry of Health, that have a lot of influence in the Ministry of Health. You need to step back and ask yourself, speak and know exactly who is who can do what before you engage. Very important. Kengasong has said, good science and good politics creates impact. And recently I met Peter Piot, because you need to engage where these decisions are taken. If you continue to shy, saying, oh, politicians, that's crazy. The system is never going to change. Things are never going to change. And I really kind of agreed, although some people don't agree, that we certainly need a lot of more good people in active politics. we can no longer continue shying away from politics. No way. Not everything is written in the books. So if there is one course or one subject or module that I'm very interested and I always teach it, whether it's on the syllabus or it's not on the syllabus, is how to think, read, and write. Do you think people know how to think? You're wasting your time. People don't know how to think. And it's not of their making that they don't know how to think. You can't think in noise. People don't know that you can't think in noise. People don't know that they need to set out time to think. So, profs, that is a course. It's so important to integrate, to teach how to think. Most importantly, with the Gen Zs that are just overwhelmed with everything. The second is how to read. I have already mentioned information pollution and information consumption. How can you manage these loads of information? How should you read? Where should you get the information from? And how to write, because we have to write. But there is a lot of information. How can you write for impact? Because you have to write. As an organization, as a scientist, if you can think properly, you can read properly, and you can write properly, it's a very huge competitive advantage for you. Not only for consultancy roles or for funding. I can tell you for free. So at times it's good to sit back and just kind of explore these unconventional areas where you also have funding, you know. Like, and it's certainly going to take a bit of thinking to sit back and ask people who does what, who can fund here, you know. There are diplomatic representations that fund specific areas. The Netherlands used to be SRH. Germany, they are good now on climate and health. South Korea, they are good on capacity strengthening, youth entrepreneurship. So those are areas, don't only focus on Gates, welcome. No, there are other areas where you can get money. But you need to sit back, think about it, and ask, make some intelligence to know exactly what is happening where. I think I'm not going to insist on the fact that cross-sector collaboration now is a given, where academia, policymakers, implementers, and all that, you stand out more when things are kind of integrated. Okay. I will go back to my role 4 years back. This is very important. So what is going on in the program officer's mind, that your program officer at the Gates Foundation or at the Wellcome Trust? So I want to tell you what is going on in his mind so that you should not annoy him. They like people that are enthusiastic. Nobody does not like an enthusiastic grantee. Be enthusiastic. Enthusiasm means if you go for a presentation, don't present as if you are sleeping or somebody has died. Have good slides, not bad slides like mine. Get some animations and stuff. That's so important. Timely reporting. Some of us in the continent, at times, I don't know whether it's a curse or report every 3 months. What is difficult in understanding that you should report every 3 months? It doesn't mean that you should send a report every 3 months, but it means if you are unable to report in 3 months, a month before, you should write to the program officer so that he should anticipate that there are specific circumstances and I cannot report in 3 months. Never forget that funders also report to funders. The program officer also has deliverables. So you are not the only person who has deliverables. So please, when they say report in 3 months, kindly report in 3 months or inform the program officer ahead of time. Don't make him annoyed. Quality reporting, extremely important. Don't send a bad report, don't send it. You better don't send it. rather than sending a bad report. You get into the bad books and you are screwed. Guys, keep in touch. It's not because they said you should report every 6 months that you go and sleep for 6 months. No. That guy is a human being. If even there is nothing, every month send an email, even to say that there is nothing, that's a message. Keep in touch. It's so fundamental. Those guys are human beings. They got other things to do. I did not say that you should go and send an email that is 1,000 words. Come on. Be concise. Straight to the point. Send the message. And always, even if they have not told you, follow their social media pages. Follow activities. A report that they just published. And I said, I was really excited by that report you published in South Africa with this organization. Great work. Then you continue with your email. That's a psychology. Those guys are human beings, guys. You need to get into their brains, and you understand why you need to get into their brains. They want to be hyped. I cannot fund you and you go on national TV or the national, newsletter, and you don't even say that this work was done with generous funding from, come on, if you are the one, are you still going to give me money? Everybody loves to be hyped. Hype them. Hype them. As I mentioned, there is a human being behind that program officer. It's not a machine that is being automated. It's a human being. This is so important, and I know the experienced researchers in the room are going to connect with this. I'm sorry to say that, but that's the fact. Funders fund people. They fund institutional integrity. There's nothing you can do about it. And you are going to see why this is even so important. Funders talk to one another. If you are screwed by one funder, be assured that you have been screwed by at least 5 funders. You have to be very careful. Honestly, if you are screwed by Welcome, forget about ITRC. Forget. I know a couple. You are done. It's done. They talk to one another, and it's on the other side too. It's a good thing. It means you are good. At least 5 funders know that you are good. And let me tell you, in the course of the year, they usually get some money as they work amongst themselves. They don't come from the same, but they will not tell you that. If you have been hyping them, keeping in touch, making the funder program officer look good, the first person that comes to mind when I have some money, I will think about you. If you have been sleeping for 6 months, good luck. So important. Don't only think in the now. Always have a concept note ready. Always have something ready, because if you are in the good books, they can always twist what you have ready. It's a complete different story if you have something and you don't have something. Always have something ready, no matter how rough. Have it ready. You can always twist the story, but never say, hey, let me go and think about it. Good luck. I think I've already mentioned the fact that most funders love networks, consortia. Be visible, gentlemen and ladies. Nobody is going to come into your house to know who you are. Invest in getting good websites. Invest in having good social media. There are some photos, you go to somebody's LinkedIn profile, you look at the photo, you don't know whether the person was being bewitched from the village. Just get a good photo. Come. What's so difficult in that? This is so important. Do you know that just somebody's photo can attract you to look at the profile or can detract you from the profile. Guys, get good photos. Very critical. Treat the funding opportunity at your disposal as if it were the last, irrespective of the amount. It could be $1,000, it could be 5,000, it could be $1 million. Treat that opportunity as if it were the last. It can push you and it can also destroy you. Your reputation and your legitimacy is your everything within the space where we function. I know this person, I know exactly what I'm talking about. The question is always, do you know this guy? That's all. It's important for us to talk about networking because as organizations, we do networking as an ad hoc process. Networking should be structured and networking should be funded. It's not ad hoc. At the beginning of the year, you need to match the conferences that you want to attend, the events that you want to attend, map the people that you want to follow. Put in money for people to go to those places. Plan the networking agenda and teach people on what they should do, how they should behave when they get to those places. It's not ad hoc. The compound interest over time you can never imagine. So it's structured and it's funded. Put money for that. You never know. The solution can only be a phone call away, an email away, or a WhatsApp message away. But whom are you going to call if you have never even met the person in the first place? Or WhatsApp, or send the email. This is also very important. There are some opportunities that if you are in good networks, you have some very high level of intelligence on, you know that it's not worth the effort. You know exactly who is going in. You know who stands a very high chance of getting it. It's going to spare you most of your time and some of your money. As I conclude, I think this is important because there are also ways of provoking funding opportunities. There are ways of provoking jobs and being hired. And there are ways, most importantly now for consultants, of provoking consulting opportunities. If you are a consultant and you're only waiting for a TOR to respond to, especially now, good luck. That's so important. And somebody will ask me, how do you provoke opportunities as a consultant? If I want to work for you, I will work for you, I can tell you for free. It might not be in the next 3 months, 6 months, 1 year, but I will work for you. Fact. I will map everything that you are doing, identify your gaps, and I'm reaching out to you. Not to say that I am this fine, attach my CV. Oh, that is annoying, especially now. I am bringing you a value proposition that I have read, I have understood. In my understanding, this is the direction that you are taking. What I stand to bring to the table is this. I am open to a discussion to see how we can collaborate. Please attach my CV and value proposition. You cannot ignore me. It's not possible. And it's cheaper now for employers because HR, that's a lot of money. You receive like 600 applications, most that are AI generated. You spend time setting up interview panels, and at the end, you are not even getting the candidate. But I have already come to you to tell you your gaps and tell you exactly what I have to offer to help you. I'm saving your time, and it tells you that I have interest, genuine interest in what you are doing. Then you will hire me. This is not taught in school, but those are the techniques I've used, and they have always worked. And when you have your pitch, and you know that you are supposed to meet somebody, please. The pitch is about 90 seconds. Can you just take 10 to 15 minutes and just practice like 5 to 6 times? And maybe practice again 2 to 3, 5, 10, 15 minutes before you meet the person. It makes a complete difference. It makes so that when you meet the person, it's a song. It makes a complete difference. Spend a bit of time, please, and practice. My last slide, because I imagine that we can have a lot of early career researchers in the room. And this is also important when you are preparing your concept note to keep. There are things here that are not going to tell you, but they are going to count when they are evaluating your concept note. So when I write my concept note, this to me is my checklist I check. Have I spoken on impact? Is there anything related to skill? Have I articulated equity, inclusion, and gender? Can somebody identify something around sustainability? Is there any strategic capacity strengthening component? Is the science sound? Am I talking collaboration? Equitable collaboration, equitable partnerships. Do I have a real multidisciplinary team? How is my budget? How can I compare with competitors when it comes to the budget? Am I really innovative? And how do I plan to communicate the findings when it's done? Nobody will tell you, but if you have a concept note that captures all of this, even if you are the program officer, are you not going to take a second look? Okay, as I mentioned, I knew that I had a very unstructured format of presenting, but I thought we are living in a very challenging role, and the other information can easily be found on Google and ChatGPT. So thank you very much, and I'm happy to answer any questions. That's a question. You can shout.
Thank you so much. That was absolutely excellent. But please tell us, because in my little experience, grooming matters. Grooming matters. So maybe give a word on that.
That's an excellent question. And if there is one thing I think the generation that just came before us and this generation we are failing on is we don't reward the most important things in academia. In my view, I have argued that the most important criterion for promotion is the quality of your mentorship. Anything out of that is completely secondary. You have a choice to make. If you think the salary in the university is not good enough, go elsewhere. If you have decided that you want to be in the university, it's not a favor that you have to provide quality mentorship. You have to. So if we render this into our systems so that that becomes something that we do by default, we have to, the dynamic changes like just completely. And there are people, I really think, what I needed, or what most young people need, they don't need resources. They don't need your money. They need a change in mindset. They need a spark to make them understand that there is possibility. They need a change to tell them that this is how to do stuff. We say grit. Children have to be taught what is grit and why grit is important. But a student is only going to be taught, or is only going to connect with that if a mentor has the time to spend with the student to inculcate some of these things. But how much time do we actually have spent with our students to inculcate some of these things? You have a student, it's not because it's a master's student that you expect the student automatically to know how to write a paper, or is a PhD student to know how to write a paper. No. You are supposed to teach the student how to write. How many of us actually spend time to teach our students how to write? And now writing is really just so important. And so what I do with my students is the first week is how to write an abstract. How to phrase a topic, because a topic should be sexy. Come on. How do you phrase a topic? How do you write an abstract before you go on to... They are supposed to be taught. Because at the end, it's just writing concisely and communicating concisely that is going to matter. It comes with experience, yes, but how do you expect a student that you have not even given the opportunity to have the experience to come up with high quality work? So I completely agree with you. We have failed, and we have to do better around that.
Thank you. Any other questions?
No.
And Professor, that question is being taken. I want to urge you to take 15 minutes, maybe during break time with these young ones. I think you have a lot of words of wisdom that they can benefit. Maybe tomorrow as you're around. Yeah.
Okay, that's okay. Yes, I can.
Or do we still have a long way to go?
That's an excellent question. Thank you. So there is a piece of work that we are actually doing on, which is around building an African think tank for a fit-for-purpose workforce for the continent. And one of the key work streams is AI. AI as creating opportunities within AI, and AI as leveraging across agriculture, health, and education to create opportunities. Three things, in my view. AI will not take away anybody's job, but AI is going to take away your job for free if you don't keep pace with AI. I can assure you. You have to keep learning. You cannot do without AI. In my country, they will say, you either deal with AI or AI deals with you. There is nothing you can do about it. That's a fact. And AI is an opportunity that there is a course that we are actually structuring, Global Public Health, Entrepreneurship, Innovation, and Leadership. And we are actually, because I just realized that people don't even know how to prompt. So in that course, we're actually going to be teaching advanced prompt engineering for global public health. It's there. People don't just know how to do it, and it's an opportunity that you can't. It's there. It's going to enhance everything. If you don't use it, it's going to push you aside. That's a fact. But using it ethically, responsibly, and AI governance, that's another discussion. But if you look at the data, South Korea, let me remind you that South Korea is a country. Yeah? When you look at the global investments, GDP US dollars. South Korea, I think they invested about 3.3 billion US dollars in 2025 on AI research. Africa invested 0.1% in AI research. And the 0.1% was concentrated in 4 countries. Africa is 54 countries. Nigeria alone is South Korea like 19, 20 times. It's just to tell you the work, where we are. 3-4 years ago, disruptions globally used to happen every 3 to 5 to 8 years. If you speak with people working on AI, every 3 to 6 months there is a disruption. I have a friend at Yale, data scientist. They have been working with somebody at Hopkins to solve some statistician. He went to China for 1 week. He came back and he solved all of those issues. It's just to tell you, every minute that we are wasting to actively invest in AI is a gap, those are iniquities that we might not catch up in 5, 10, 15 years. As we are waiting and sleeping and watching football, others are actively invest. Like I was in South Korea, what children are doing, here you talk about coding is like something extraordinary. Those children do those things. 6, 7-year-olds, 8 years, coding to them is the normal. I'm instead giving hope. There is hope. It's just to say that we need to be real, that we are not doing enough, and we need to sit up. Yeah.
Thank you so much. A rousing applause for Professor Engelbert. I hope we get time to engage more, both in this session and maybe beyond, but thank you very much for opening our eyes. So ladies and gentlemen, we are going into a session where we are going to talk about health systems and equity. We have 4 presentations and then a Q&A. No, and then a guest lecture, and then we go into the second round of presentations. I want to beg all of you for your patience. We started late. The day has bled into into presentations and into sessions, but there's a lot we can learn today. So without further much ado, I want to call up the next presenters, Girma et al., Puya, MA, and Owor et al. Are they here? Please come and sit near. These presenters are going to show us the gaps, the strengths of our health systems. They are going to try and address, through that research lens, what can be done to better strengthen our health systems in order to reduce maternal mortality. I want to welcome Girma, whose presentation is When Knowing is Not Enough, a qualitative study of health systems barriers to PPH management in Eastern Ethiopia. Karibu sana. Going once. Going twice. To the next one. Puya. Puya has not 1, but 2 presentations. The first presentation is on the role of quality improvement and enhancing nurses' attitude towards the use of carbetocin to improve maternal outcomes at Diani Health Center, Kwale County. Puya also has another presentation on incorporation of maternity open days in routine facility-based enriches to improve uptake of skilled maternity deliveries at Diani Health Center, Kwale County. Karibu sana, and let's give her a clap as she comes forward.
Okay, good afternoon. My name is Mwanasiti Puya. I'm a nurse midwife at Diani Health Center, Kwale County. I'm going to present a quality improvement initiative which we did in Diani Health Center, Kwale County, at a period of 6 months from October 2025 to March 2026. So the role of quality improvement and enhancing nurses' attitudes towards the use of carbetocin improves maternal outcome. So PPH, as we know, is a leading cause of maternal mortality in Kenya. Both in Kenya, as a county, all of us were contributors to that percentage or to that number which is there nationally. As a country, as we know, we are at 355 per 100 live births, 100,000 live births. As Kwale County, we are not spared. According to the Kenya Bureau of Statistics, we were at, back 2019, we were at 464 deaths per 100,000 live births. In that, we are almost double the number of PPHs in the country. So oxytocin requires refrigeration, limiting effectiveness in low resource settings. WHO recommends heat-stable carbetocin for PPH prevention. Kenya MOH has incorporated into maternal care. So apart from the oxytocin which we use in the facilities, WHO came with an option of carbetocin in the prevention of PPH in our setups. So the problem statement, the challenges which we had was inadequate cold chain system. Some of us in our facility or in maternity departments, we didn't have the refrigerators which are required to store the oxytocin as per that time. So delayed emergency responses. Also, we have limited confidence in new uterotonics. So the opportunities which we had was the quality improvement to increase the heat-stable carbetocin uptake within our facility. So our main objective to this was to assess the role of quality improvement and enhancing nurses' attitudes towards heat-stable carbetocin in preventing PPH and improving maternal outcome. So the quality improvement approaches which we took was capacity building. We had 12 nurses and midwives within our facility. So the thing was to do capacity building to those nurses and midwives concerning heat-stable carbetocin. So also we did continuous medical education, blended mentorships, and we monitor all these through our monthly CQI meetings, monitoring using maternity registers and delivery records within the facilities. So the key results out of all, 12 nurses completed the capacity building through blended mentorships and continuous medical education. So out of these, 78% of the nurses, they reported positive attitudes towards heat-stable carbetocin, citing its effectiveness, ease of administration, and independency from cold chain storage. So by that time, the carbetocin, during that period, the carbetocin uptake increased from 0% at baseline to 73% after implementation. All that, it's not that we didn't have the heat-stable carbetocin at our facilities. It was there at our pharmacy stores, but the nurses, they were not capacity builded. Also, they didn't know the impact of heat-stable carbetocin. So referrals to the county hospitals decreased by approximately 31%, indicating improved capacity to manage postpartum hemorrhage locally. So our implication was to improve adherence to evidence-based practices, better preparedness for PPH prevention, reduce dependency on cold chain storage, potential reduction in maternity morbidity. So the conclusion and recommendation was that training, mentorship, and reliable heat-stable carbetocin supply improved uptake and maternity care. So the recommendation was that we have to scale up nationally or to other peripheral facility. We ensure an interrupted supply of the heat-stable carbetocin, also to sustain mentorship and the CQI, that is continuous quality improvement programs. So our acknowledgement is to Kwale County Government, Department of Health Leadership, Diani Health Center staff, nursing team, Staisha Pwani program, Japaigo, and the Diani community, that is the catchment population within it. Thank you.
Thank you very much. I'll ask you to continue with your next presentation. Time is 5 minutes.
Okay.
As technology starts to cooperate, a war is a war in? Continue.
Okay, the next abstract or presentation is about, the title is Improving Skilled Maternity Deliveries Through Integration of Maternity Open Days into Routine Facility Enrich Activities. So the background was maternal and neonatal mortalities remain significant challenges within the country and to our county too. Skilled birth attendance saves lives. However, mothers face numerous barriers to facility deliveries, all because they fear of facility deliveries, misconceptions, they have limited awareness about the services which we offer within our facilities. Also, they have poor engagement with health facilities, especially the staffs and the environment too. So the annual center's solution was quarterly maternity open days integrated into the routine facility enrich activities. So our objectives was to increase uptake of skilled maternity services and facility-based deliveries through enhanced community engagement. So the specific objectives were increased awareness, reduce fear, improve birth preparedness, strengthen trust, and increase skilled deliveries. The interventions were for the maternity open days were CHP, community mobilization, the community health promoters. They do community mobilization of the antenatal mothers. Apart from the ones who comes to our facility for their routine NC, we also want to target the ones which are left at home through the community health promoters. Health education sessions, guided maternity tours, introduction of maternity staffs, birth preparedness education, and then follow up by the community health promoters while they're back to the community. So that's the approach, the flow: community mobilization, health education, facility tour, birth preparedness, and facility delivery, back then follow-ups by the CHP to the community. So the key results, that was from December 2025 to May 2026. As we can see there, our deliveries increase in percentage was 61.1% increment. So the implication, community impacts at least 40% reduction in childbirth anxieties, and this was done through the self-reports, that was done through the self-reporting feedbacks from the mothers who came to the facility during the maternity open days. 90% increased in awareness about the maternity services which we offered, and that's why they went back and make a decision of choosing our facilities as their best choice for their time of deliveries. So increased trust in maternity services, increased referrals, and self-presenting mothers. The success factor was that we had a strong community health promoters involvement, early ANC engagements, guided maternity tours, friendly maternity staffs, community ownership, and low implementation costs. At least it had low implementation costs because we just integrated into our routine facility-based enriches. So the key message is that women are more likely to deliver in facilities they know and they also trust. Conclusion, maternity open days, they increase facility deliveries at our facility specifically by 61.1%, reduce the anxiety of the mothers concerning the skilled deliveries, improved awareness about the danger signs, about how they will deliver, about how the approaches from admission to discharge within the maternity unit. Strengthen community trust, also scalable and low-cost intervention. Recommendation, scale up to other primary health facilities. So also we acknowledge the Kwale County, Diani Health Center staff, Stawisha Pwani, Japaigo, Diani community catchment population, and also the community promoters within the Diani community units. Thank you.
Thank you so much. Because we didn't have the other two presentations, I'm going to ask you to take a seat, and then we are going to do Q&A in general with the next round of presentations. So thank you so much for sharing with us what's happening in the beautiful Kwale County, and we encourage you to keep on. We have a number of presentations. We have almost 8 presentations. I'm going to call the presenters and see if they are there, which will help us plan this session. Masood, Wanji, I saw Wanji. Mwangi Chorongo, if you could please come forward. Kimani, and Okongu. Okay. I hope I haven't ambushed you. Are you ready to present? Okay, so we are going to start with Mwangi, and then we go to Chorongo. You're together? Okay, karibu sana. Give an encouraging clap.
Good afternoon. My name is Grace Mwangi. I'm a midwife. My name is Grace Mwangi, a midwife from Malit sub-county in Kilifi County, and I'm going to present our study entitled Maternal and Neonatal Outcomes. Maternal and neonatal outcomes among obstetric referrals in Malit sub-county periphery facilities, that is in Kilifi County. So as we have all heard in the morning, we really appreciate that maternal and perinatal and neonatal mortality are high. And I would like to really point about Kilifi County, where we have a maternal mortality ratio and a neonatal mortality ratio of above the national one, 532. Can I be assisted? I cannot be able to. It is not happening. It's not moving. So I was saying that in Kilifi County, we have a maternal mortality ratio of 532 and a neonatal mortality ratio of 24. And also, Kilifi County is one of the 20 counties with a high burden of maternal mortality, and more than 30% of those are due to postpartum hemorrhage. So we wanted to assess the maternal and neonatal outcomes among the obstetric referrals that were managed at Mari Sub-County Hospital, specifically to be able to describe the outcomes of the mothers and also the newborns. At the same time, be able to identify the factors that were associated with the outcomes, and more so the poor outcomes. Mari Sub-County Hospital is the main referral hospital for the periphery facilities, and also it receives referrals from the neighboring sub-counties. And the maternal mortality in the facility has been high, despite several interventions. And those mortalities were being associated with referrals. So there was need to be able to really assess to determine whether the referrals were the contributors of the high maternal mortality. So we did a retrospective study taking 6 months from January to June 2025. And 6 records were reviewed. And specifically, the data was from the maternity register, the referral register, and also the patient files. There was some limitation in a way that you could find that some of the records were incomplete, and at some areas the data was missing. So the key findings, most of the mothers were between 20 to 29 years, showing the peak of reproductive age. 82% of them were referred during the intrapartum period, and for those that were, the rest of the proportion was during the postpartum period due to postpartum hemorrhage. 87% of the mothers had attended ANC, but just a small proportion of that were able to achieve the WHO recommendation of 8 contacts, that is about 1%. Looking at why the mothers were referred, most of them were referred due to prolonged labor, 25%, with 20% due to non-reassuring fetal status. Then postpartum hemorrhage and hypertensive disorders of pregnancy accounted to 11% each. Now looking at the maternal outcomes, 95% of the mothers were referred or were received in the sub-county hospital in a stable condition, while 5% were in critical condition. Then 99% of the referrals was survived. We had 3 maternal mortalities accounting to 1%, and those 3, 2 of them were due to postpartum hemorrhage, and 1 was due to anesthetic complication. Looking at the neonatal outcomes, it was slightly lower than the maternal outcomes, with 91% survival, and out of the 91%, 18% had birth asphyxia, while 7% were stillborn. So in conclusion, the maternal mortality outcome was higher. However, the referral also contributes to maternal mortality in the level 4 facility. For the neonatal outcome, it is still a concern, more so due to the high rates of birth asphyxia and also stillbirths. And strengthening the emergency obstetric care and also the referral, timely referral, would be able to improve the outcomes of the mothers and the newborns. Our recommendations, which most of them are being implemented, we recommended strengthening of the referral system through coordination, communication, and also documentation. And the county is doing so much to improve the referral system to ensure that there is timely referral. Improving the labor monitoring through the recommended tools. And I will say that you've gone a step ahead because like in the level 4 facility, all the midwives have been sensitized and mentored on the use of the labor care guide, and they are using it even in the EMR, the Taifa Care. Also, we recommended building provider capacity through EMOC mentorship, and there has been EMOC training. And also, we are doing EMOC, the in-facility mentorship, having EMOC commentative sessions, and also simulation drills in order to enhance the skills of the midwives and other service provider to be able to deal with the PPH and also other obstetric emergencies. Also, conducting continuous referral audits so that you can be able to track the gaps and be able to action and be able to bridge those gaps. I would like to acknowledge my investigators, also Mari Sub-County staff, the Department of Health, and most appreciate also AMREF Health Africa through Uzazi Salama program who supported this study. Thank you.
Thank you so much. Okay, we go to the second one, Kimani. I believe you have 2 presentations. Okay, you can run through.
It's a tough one. Huh?
It's a tough one.
Tough one.
Good afternoon. Lovely. Thank you for the opportunity. My name is Kimani Ndungu. I'm an obstetrician gynecologist at Consolata Hospital in Kubu, level 5 faith-based hospital in Meru. And today we are happy to share our institutional experience on enhanced recovery after cesarean and propose how we feel it could be a health system strategy for safer and more equitable surgical maternity care. So ERAC, or Enhanced Recovery After Cesarean, is an evidence-based bundled approach to handling cesarean sections. And there's good evidence to show that it has tremendous benefits in terms of reducing pain, fewer complications like surgical site infections. Patients have faster recovery, better bonding, and higher satisfaction. But despite this is applied inconsistently, especially in settings such as ours. And this was the case even in our facility. And that's what made us think of coming up with this. We are talking about postpartum hemorrhage. Of course, it's one of the things that causes a high obstetric burden. And so we'll show how, through implementation of this, we feel that other obstetric outcomes can be addressed by this. And so we implemented this in 2022, and it was mainly as a workforce and system-level quality improvement strategy. And to date, we analyzed the data till end of last year. 4,272 cesarean sections have gone through this ERAC protocol. And as I've said, it's a standardized multidisciplinary pathway. And these are a few of the outcomes that we looked at, which we'll see in the results. In a nutshell, this is the ERAC pathway. It's a continuum from preoperative, intraoperative, and postoperative. So how I would probably summarize this is traditionally how we used to perform our cesarean sections. We used to give patients antibiotics after cesarean. We used to give them IV analgesics after cesarean. So we went and looked at the evidence, and we showed that there is a role of multimodal analgesia, and this I think was the game changer for us, where we now started using intrathecal morphine when we were performing our cesarean sections. The consequence of that was that postoperatively, our patients did not need IV antibiotics or IV analgesics. And so all our post-op moms usually would be on oral analgesics. We did an evaluation at the end of last year, looking at our data, and we had a checklist to see if all the bundled elements were there too, and our compliance was close to 96%. We wanted to look at the recovery of these patients, and so we used a validated tool called the OBS-QOR, and we found that mothers reported 92.7% recovery. We also found there's an improvement in terms of breastfeeding, from 68% to 94% of our moms starting breastfeeding within 1 hour of delivery. Surgical site infection, we noticed a decrease from 8.2. Previously, there was inconsistent use of antibiotics, and currently 2.1% is the rate that we are in. And 95% of our mothers do not need opioids after delivery. So ladies and gentlemen, this is a PPH conference. So those who are not obstetricians may be wondering, what does this have to do with PPH? And so this is a slide that I think ties that in. So remember I said that preoperatively, before this strategy, we used to give patients a whole bunch of medications. But now, once we reduced that and we found still improvement, we looked at the numbers and we found that we had a 59% reduction in cost. Here we counted everything, from the gloves to the giving set and the analgesics. So from about 4,000 to 1718. It may not seem like a lot of money, but when you crunch the numbers, it came to 10.5 million. Now, our hospital operates within a tight fiscal space, and so one of the challenges that we had on matters PPH was availability of tranexamic acid, the calibrated drips, and even carbopros, which we use as a second line. And so based on from these savings, then we were able to justify that, and the hospital was able to help us procure this. We also had freed nursing time, because after delivery, our nurses are not trying to fix IV lines because our patients are on oral medications. For those that may be considering an ERAC implementation, you need multidisciplinary buy-in. We feel this is not something that you just come and force on your teams. We did a lot of staff training and engagement, and also patient education. Most of our patients are used to having post-op medications, so we had to educate them about this. We also had a standardized checklist, and we do audit and regular feedback. So what we've learned is that this is feasible in low resource settings such as ours, and measurable gains as I have illustrated. And so as a workforce strategy, we propose that this can be adapted in very low resource settings, and we're happy as we speak, a couple of facilities where we've been able to share this institution with, this data with in Meru, have started applying some of these aspects, and it's sustainable. I mean, 10.5 million over 4 years, I think is not small change. And I think eventually, in terms of equitability, standardized care pathways will bring equity in terms of the gaps in outcomes. Thank you all.
Thank you so much. And you're going into your second presentation.
Lovely. So I'll segue into the next presentation, which is also an institutional experience on training in technical skills. Now, we've talked about PPH, we've talked about oxytocin, the 40s, but what is increasingly found to be important is that the cognitive and interpersonal skills complement this. We know that if a woman bleeds, we need to do this or the other, but why is that not done? And so this is what I'll be talking about in the next 4 minutes. So the 4 main ones that we looked at are situational awareness, communication and teamwork, decision-making, and leadership. What is the problem? If you look at the confidential inquiry into maternal deaths, an oft-quoted figure is about 70% of adverse outcomes have failure in technical skills. Indeed, this was true in our facility, where we did an audit in 2020 during the pandemic, and we found that communication breakdown, delayed recognition of deterioration, and delayed escalation were significant contributors. And this was the strategic framework that underpinned our work, where we hypothesized that poor non-technical skills leads to error, for example, failing to recognize that a patient is bleeding and leading to adverse events. And so what we thought of doing is, if we're able to address these non-technical skills, could we avoid or reduce some of these adverse outcomes? So the first one was situational awareness, and this is our curriculum. We borrowed this, my favorite show in National Geographic, I don't know if you guys have watched it, is Air Crash Investigation, but you should never watch it if you have a flight. But we borrowed it from the aviation industry. And if you look at that cartoon, these are pilots, and then they see a goat. And so one of them asks, what is this mountain goat doing there? So that's what we're talking about in terms of situational awareness. Perception that you've seen a goat, and it's a mountain goat. But then comprehension, what does this mean? It means that I'm probably at the same level as a mountain. And so projection, what should I do? Probably elevate. And so this is actually the main thing in terms of our curriculum. Communication is also something big. And so we train our teams, from the midwives and the doctors, on SBAR, situation background assessment recommendation. That is standard in terms of our communication. Closed loop communication, where if I'm in theater and I need oxytocin administered, then I say administer 10 units of oxytocin. Then whoever is supposed to do that repeats that message. Directed communication, where we don't say, I need blood, but we say, Dr. Kireki, could you be kind enough to see if you can get blood? And lastly, safety critical language. So all our midwives and interns and doctors, we train them on safety critical language in terms of, we tell them that within the first 30 seconds, whoever you're calling should know what it is that you need. So we use the aid mnemonic. I need to consult you, advice. I need to appraise you, or I need you to do. Please come. We have shoulder dystocia. Leadership is also something else that we train on, and we have protocols which we have in our institution, and every new staff, from the midwives to the interns, is taken through the same. We also have feedback, timely feedback, and we debrief after events. Then we've also emphasized on a flattened hierarchy, so that the midwife does not necessarily have to call the intern, who will call the MO, who will call the consultant. So how did we implement this? Simulation-based training, but we went above that. We did not just, for example, for PPH, just have a dummy and talk about, IV access, oxytocin and whatnot, but we would assess on how we are doing in terms of the non-technical skills. Then we'd have didactic lectures and teachings. We introduced something called a daily safety huddle. So every morning, when the nurses or the midwives are handing over, they have a safety huddle for 5 minutes, where they say, for example, we have this patient who is at risk, say, of PPH, maybe a patient on induction or twins. So everybody has that same mindset. And we also borrowed from the non-technical skills training for surgeons, where we use the behavioral system to assess our teams. When we looked at the results, we used the Kirkpatrick framework, which is something that's used to evaluate training interventions. And we found that out of the 150 staff, so far by December we had trained 150. The bulk of this were midwives, 72, 60 interns and 18 medical officers. 96% of them expressed satisfaction and were quite happy with the training. We also found that there was improved performance scores in the simulation assessments. And in terms of how this translated to practice, the last time we checked by December last year, our safety huddle compliance was 94%. This means that 94% of the days this form is filled. I think where we were quite happy is the WHO patient safety checklist, and which is at 100%. Tying this now to PPH, our hospital was part of the FIGO LDI study, and so we collected data on PPH, and we would look at all the cases of PPH in terms of emotive compliance, and by December last year, we were at 96%. Decision to delivery interval improved from 40 to 16 minutes. And 100% of our patients who had preeclampsia diagnosed, severe preeclampsia, had seizure prophylaxis within 30 minutes. I mean, the biggest thing that excited us as I finish is the last 4 or 5 numbers there. We used to have an average of 1 to 2 maternal mortalities per year. And we implemented this once we implemented this, it took time. But from 2 years after we've implemented this, we've not had any maternal mortality. And even in terms of perinatal asphyxias, we used to have about 21 per year. By last year, we had 3, and none of them were related to intrapartum events. It's certainly not been a walk in the park. We have staff turnover. The county comes, advertises jobs after you've trained the team, but we have to contend with that. And of course, there's a competing clinical workload. And culture change takes time. This was not a magic bullet that we started and mothers stopped dying. But when you look at the data, of course, including other things, but we feel this also has contributed. Those that may be considering embracing this as a workforce strategy, we feel that this is replicable, but you need a context-specific curriculum like the one that we've done. It is sustainable, especially once it's entrenched in the culture, and eventually downstream, the adverse obstetric events are going to be addressed. I thank you all.
Sharing that wonderful information. I'm sure we are a bit wiser because of that. I want to ask all of you to wake up, stand up, be upstanding. And stretch the way you stretch in the morning. Just, those ones even do this, eh? 30 minutes to stretch. Not a second. Turn around and greet the person behind you. Tell them we are going strong. Yes. We don't stop until it ends. Okay, we can now take a seat. I'm sure we feel a bit refreshed. Okay, we feel a bit better? So we are almost, okay? We have one more presentation by Waji. 5 minutes. And then I'm going to call Dr. Victor Mivumbi after her to present. And then we conclude with a nice Q&A where you ask any and all questions before we take a health break. So Waji, you have 5 minutes. Karibu.
So you can't start until my thing is. Good afternoon, everybody. Yeah, but Dr. Lara, can you please wait for my slides to be mounted before you start the timer? From the beginning. Yeah, good afternoon again. Yeah, so I'm sharing this afternoon on measuring MPDSR quality using WHO indicators and an adapted ALMA scorecard. It is experience from a tertiary facility in Yaoundé. Yaoundé is in Cameroon. So I want to start with a little bit of background just so those who are not in the field can understand why we have to talk about why we did this study that we did. So MPDSR is learning process which is meant for quality improvement. It is used for following up maternal and perinatal deaths. MPDSR actually stands for maternal, perinatal deaths, surveillance, and response. Sorry. So it's essentially about following up those deaths, learning what we can learn from them, creating recommendations, and then acting upon them so that we put it back into the system and prevent further women from dying from the same cause. So in some certain places, MPDSR sessions are not held. And that's where we would ask the first question. Are these meetings happening, and why are they not happening? But in the second instance, when they are happening, it's not just about us being contented that those meetings are happening. We want to ensure that we're actually getting implementable and measurable action that is coming from those sessions. So, like we've said, MPDSR has been adopted widely, but implementation is really quite variable. And so the essence of this study was to be able to judge whether the sessions that were carried out according to normative guidelines, which are the WHO indicators. And we went a step further. We wanted to know whether of the recommendations that were derived from those MPDSR sessions, were they actually carried out, and can a scoring system be extracted from that system of recommendations so that it makes things more actionable, like creating some prioritization on it. So this was a retrospective cross-sectional study on analyzing MPDSR sessions, and it was using, of course, the minutes from those sessions, attendance list, and also other supporting documentation from the hospital registers. It was carried over 5 years, and during that period of 5 years, 122 maternal deaths occurred, and 433 perinatal deaths equally occurred. So the framework against which this scoring was done, there were 5 indicators which were taken from the WHO normative guidelines on MPDSR quality improvement, and we were interested in seeing issues around the meeting frequencies, around the timeliness of the meetings, around the composition of the team, around the quality of the recommendations that were framed at the end of the sessions, and if overall there was sufficient coverage. So the WHO guidelines actually has target metrics for each of those indicators. So it was us trying to see if those sessions met those targets or if they were short of the target. So during that 5-year period, 79.5% of maternal deaths were reviewed, and only 13.8% of the perinatal deaths were reviewed. This graph just shows like how the curve of how it evolved over those 5 years. The curve at the top is for the maternal deaths, and the one at the bottom, like we can understand, is for the perinatal deaths. Now, on this slide, we have the performance of those different indicators throughout the 5-year study period. I would walk you through the first one at the toppermost, at the top, which is the indicator on interdisciplinary team participation at MPDSR sessions. So for that particular indicator, we can see that on the first year, about 75%, it was 75% target met, and beyond that, it was 100%, which means that indicator was very well catered to. And we would go now to the one that is at the bottom. The line at the bottom is about the quality of the recommendations that were framed during those sessions. Those recommendations have to be smart for them to be actionable. So that's what the guidelines actually request that they be tested. So smart recommendations fell short for that team. And beyond categorizing these indicators, we were also interested in creating like a prioritization scheme where we're not just saying, 5 recommendations were made. We're trying to see if can we create some set of urgency around it? Can we push people or decision makers or even those who are participating in those sessions to know that we are doing good and we are not doing bad? So creating like the green, the tricolor system where all indicators that were less than 80% were considered as, that were above 80%, were considered as being met. Those 50 to 80 as on track, and those less than 50% met were lagging. So as we can see on the screen, only 36% of the indicators or the recommendations were met, and up to 24% were lagging, which means MPDSR sessions are being held regularly, the team is there, but the outcome or the impact is not gotten. I think 25% is quite a big number for such a session that takes in a lot of input, a lot of resources and people's time. They're already showing me that my time is short. So the critical gap is on smart recommendations. We have to ensure that recommendations are smart. And if I would want to drop out by just leaving this with us, that it's what this study has added, that it is capital for us to make sure that our recommendations are smart, and that it has equally taught us that beyond just having the sessions, we can create a scorecard around it that is going to create that source of prioritization for the entire team. The study had some strengths and limitations, and as take-home message, we are called upon to standardize recommendation templates for our teams. It's not just about saying we should start doing this. We should make sure that we have a template that is given out to all the members of the team, and each of the SMART criteria are met as they carry out the execution. And then we should also train the members of MPDSR committees. It's true they say multidisciplinary, but the members have to be taught about what it entails and how to go about it. Thank you.
Thank you. Thank you very much, and thank you for keeping time. So we finally round up with a guest lecture, marching towards SDG, the Rwandan experience. A lot of good things has happened in Rwanda, and key among them, I think you have one of the lowest maternal mortality in the continent. So good to sit and learn and hear what Rwanda is doing good. Karibu, Dr. Victor Mivumbi.
Thank you. Sorry, the presentation is not opening, so it's going to take a little bit time. Can I bring the machine? Ladies and gentlemen, good afternoon again. Good afternoon. I hope we are not sleeping. Yeah, so it's really a pleasure to be in front of you today, this afternoon, to share the Rwanda experience toward SDG 3. And first of all, I would like to thank colleagues from Cox, Kenya, Moses, for inviting me to be here today. And we do share the same goal for ending PPH. And we have started this journey together because even in Rwanda last year, before our conference, we did a kind of work for ending PPH in Rwanda. That was the first one, but we have been inspired by colleague from Cox. Second, being here in front of you as Rwandan remind me being part of the East Africa community, and we do share the similar issues in terms of saving mother, avoiding women die during giving birth. So that's really critical. So maybe presentation. My name is Victor Mivumbi. So currently I'm standing here representing the Rwanda Society of Obstetrician and Gynecologists as the chair. And also currently I was elected as the Secretary General for AFOG, which stands for Africa Federation of Obs and Gyne. But in my ordinary work, I work for DHPEGO in Rwanda as the Chief of Party for Momentum Country Global Leadership. I'm obstetrician is education background. So as you can see on these slides, so we're going to share some of the experience, high-level experience for Rwanda toward SDG 3 and also progress. It's quite not really so different from other sub-Saharan Africa because we stand here talking about the PPH. PPH is really in Sub-Saharan Africa an issue because the first killer for women is the postpartum hemorrhage with different causes. And we know a couple of interventions have been discussed, WHO, UNFPA, people are being together, but the effort is there, but when you look at the outcome, it's not yet sufficient to be able to say that we are already working and we are reaching the goal for reduction of maternal mortality due to PPH. So as Rwanda, we have been privileged also to gain and have some of the interventions and good leadership toward the population. As you know, Rwanda is a very small country, as you can see. It's a dot in Africa. But, you know, one more thing is we are already very congested because when you look at the population and the size, we are among the high density countries, Rwanda, because it's over 500, you can imagine. The country is very small, but with a young population, over 60%, it's less than 20 years. So you understand, so we need to work with the population. And as you know, SDG 3 stands for all aspects for health, including maternal, newborn, communicable and non communicable disease, but also universal health coverage. So Rwanda is among the country for this commitment. And Rwanda has integrated the health into government priority, focusing on equity, decentralization, but matching with economic growth. So we are look at this in a holistic way. And through the Ministry of Health, so with different stakeholders, every 5 years we are developing strategy, what we call health sector strategic plan, with all guidelines, the guidance for tackling issues related to the health, starting at the all health system. And the Rwanda has prioritized for more vulnerable population using community approach and the social protection for increased health progress. Just to share with you the Rwanda health system, as you can see, it's a pyramid, but the front line and the emphasis is on the community, as you can see. That's the front line whereby community focus are managing above 90% of the diseases. So we started this program in 2005 with very limited number of community health workers, and then those people were volunteers, not really healthcare providers who were trained and then have been elected within the village. So each village initially has between 100, 150 households. Initially at the beginning, it was one community focus who was basically in charge of maternal, and then later on, we added 2 more for Binom, who were in charge of child and family planning. But currently, the program has really evolved a lot. In such way, now we have 4 community focus by village who are polyvalent, who can really provide the services across all technical area, not only focusing on maternal and the newborn and family planning, but adding also NECDs. The next level is health post and health center, whereby they provide basic emergency obstetrical care and a district. As you can see those level of health system are matching with local administration along the way, with also high-level referral and tertiary services and hospitals. Talking about the current health indicators. So starting in 2000, you can see there was really much improvement in terms of health indicators. People attending and delivery with health skilled birth attendants has really increased tremendous. And such way you can see health facilities delivery has increased 217% from 26 to 98. So this was effort from really high level people, but with a commitment to low level, engaging everybody, but also with stakeholders. Looking on maternal death, it has already reduced until 2015, whereby we observe a stagnation. And this is basically across, if I'm not mistaken, the whole Africa. We are stagnant, ready to reach the target. As you know, we are now currently 149 in 2025, but as you know, we are not yet. And then we remain with just few years, 3 only, to meet the target for SDG. So, which means we need to change the way we are working. And we know the issues. The issue of accessibility, reach the right, has been resolved. But when you look at management within a facility, it's still an issue, and it is related to the quality of care. Quality of care is an issue. And currently, Rwanda was able already to map some of the gap so that we can tackle and accelerate to see if we can reach, and then it is possible. Something similar when it comes of child. There is already tremendous reduction, but when it comes of 2014-15, we are facing the same issues. And the other point, if you look at the neonatology, newborn death has reduced, but not very much as other components. This is really contributing to under 5 mortality, which is still high in our country. One of the important and pillar for Rwanda was leveraging this community system, as I said. As I said at the beginning, 90% of the diseases are managed at low level. So community focus serves as the first contact within the facility. They are able to track women of reproductive age within the household, accompanying and follow-up pregnancy women, and also conducting postpartum, encouraging women to seek for care, for antenatal care. Similar is happening as well for the newborn. So this community focus really has really contributed a lot for improvement of Rwanda health system. And currently, one of the important things, we have already left paperwork for community focus. Now they're able to use for what we call community electronic medical record to record, track, report, and also getting information from the client, alert if there is a danger sign, for instance, for PPH. And then this system is connect with the ambulances so that and the facilities so they can really act quickly for helping mother within the facility. So community focus, health facilities, ambulances are all linked in one system, whereby everybody can see the immediate issues and then they can act immediately. So they are also involved in health promotion, teaching, provide information, hygiene. And recently they were able also involved in the outbreak management and the awareness. And we have seen that this really cadre for healthcare, who are volunteer, are very trusted with the population, and so that people are trusting them, and then they can provide information, they can consult them easily. The other point which is really key for Rwanda was to make sure that everybody has access to health facilities, reducing out of pocket. In Rwanda, community-based health insurance covered 80% of the population. Those populations are not really working, but with this system, every family by head, they contribute just a minimum of fund so that they can be enrolled for medical health insurance. Obviously, if you look at really the amount, the figure, it's very limited and very low, cannot really cover. But the government has tried to look at other mechanisms to mobilize funds, using some percentage from tax, property tax, policy fines, but also some insurance they're providing fund through that pool. So this really has demonstrated a quite increasing accessibility for healthcare and avoiding risk for getting healthcare. And surprising again for this scheme is really covering quite a number of packages. This country is also covering cancer management, chemotherapy, radiotherapy, and also kidney transplantation. So basically, it can cover entire service package from low level to high level. So this has demonstrated quite one of the pillars which has served the way to reduce maternal mortality. And it's really digitalized. Every member can enroll using his phone and then pay the funds using phone without moving to any office. So it's really very easy to use. And people, what we do through Ministry of Health, Ministry of Local Governments, is to encourage the people and they can enroll. And people who are not able to get any income, the government sponsors them so that they can have this medical insurance. The other point also which is important is innovation in digital health. Rwanda was among the first countries to use this innovation of blood delivery. Currently, we are living to blood store, because with this system, every facility in the country can get blood within less than 30 minutes. So we have 2 centers in the country. One is in the eastern, the other in the south. So those centers who are driving this drone, they have store of blood, and then every time there's a request, immediately there is a communication through the system. So within 30 minutes, you can receive the blood. So currently the issue of blood delivery, it's no longer there in our country. It has started in 2016. When we started, of course, we started with trial pilot for a few districts and facilities, but currently is a countrywide. Also, in terms of digitalization, we have left paperwork. We're using a electronic medical record from community, as I said, what we call community EMR, and the facilities, they have what we call Ibuzima. And recently we have launched what we call Health National Intelligence Center, which gather all information from all facilities on real time, whereby they can even track ambulances. When there is a request, they can distribute them easily. This is something really impressive. Recently, I think before yesterday, the Bill Gates was in Rwanda, even now. is really visiting this innovation happening in the country. And all community health workers currently, there are 60,000. They have smartphone, so they can use this system. Every hospital has different devices using electronic medical record, and we can pull data easily without using, we can get individual data instead of disaggregate data. Telemedicine as well is being leveraged in Rwanda by providing courses, but also high-level hospitals, they are mentoring low-level, whereby we don't have a gynecologist. We have started a telemedicine mentoring, whereby they can even guide a GP who is conducting a cesarean section. So we have started this in some of the facilities, but it is working. So this is being done with the Ministry of Health, the Rwanda Ops and Guide, and the Big Get Fund, and seems working. Because even though I'm saying we have very much to improve, we still have an issue of healthcare workers. The recent, I think that was in 2023, when the WHO, as you know, recommend to have minimum of 4 healthcare by 1,000. But in Rwanda, it was to 0.4. And in 2023, Ministry of Health has launched a strategy which we called the 4x4 reform. What that means, this was meaning that quadruple the current health workforce within 4 years. We started that system in 2023. Currently, we are at 7.6 for the target. Looking all cadre, specialists, midwifery, nurses, pharmacists, and also anesthesiologists. So we have a numbers, and we have a target. So what I want to say here, this strategy really has helped us to grow up in terms of health workforce. For instance, if I'm saying speaking experience for OBGYN, in 2012, we had 15 gynecologists in the country. Currently, we have 140 and 300 in pipeline. What happened? Through advocates from the government of Rwanda, Ministry of Health, and the other financial entities, we did advocacy with cases found from different partners worldwide to come in ready to support this initiative. Currently, we have a budget, we have a STBF. Through even our society, we have expanded the existing university, because before University of Rwanda was only one faculty for medicine until recently, 2023. So you understand the outcome, the number were very low. But currently, by expanding, and at that time, we were just running the program within 3 hospitals. And after starting this program, we are running the OBGYN residence in 13 hospitals. So which means we hope the target will be reached soon. But of course, you understand, this is effort for everybody, but first of all, for Rwandans who are already committed. But because we were not having enough OBGYN, we had to call even foreigners. We have Ethiopians, Ugandans, some of Kenyans who are in that program, so to help reaching this target. However, challenge is still there. I'm saying we are on target to have this health workforce, but what about retention? We always in the meeting at the ministry, meeting with partners. But when it comes to strategy for retention, you know, retention is an issue across, even more in Africa, because every time you train someone, when there is a competitor, you lose him. For instance, for OBGYN in my country, there was a policy of retention. It means if you have been supported by the ministry, you have to work 5 years for the government. When the 5 years are over, the same day, there is resignation immediately, because they go in private money. The public, they are paying less, which is understandable because of the means. So that issue is being already discussed, but it's really critical. It's a critical, we are seeing it. We are developing, producing quite a number of health workers at all levels, but retention, we don't know if we're going to manage it. But of course, The first thing is to have people, but we are really trying to put policies which could help to retain people. And also, as I said at the beginning, issue of postpartum hemorrhage remain in our country because it's contributing to more than 20% of death, which is really critical despite the effort. But as I said, a couple of initiatives and the innovation are in place, and the country is trying really to implement all measures, emotive. And a couple of trials are being conducted here in Rwanda, leveraging some of the devices, suction devices, which has been demonstrated, being working, and also training people, even GPs, to be able to conduct some of the surgery measurement for tackle of these issues. But we still have that issue in the low level. And the other issues for SDGs is non-communicable diseases, but also mental health priorities, which is taken into consideration as well. So this is a snapshot of what is happening in Rwanda. If you need to know more, we can share some of the resources, but also don't hesitate to reach out to me for more information. And I believe this is a collaboration has started, and I believe it will continue. And at the beginning, I was thinking, oh, this is the first inaugural international PPH conference. Why not next year to be in Rwanda? Yeah, it's possible. It's possible. The important is the collaboration, partnership, and the willingness. And I believe being here, all of us, and I know also my country are very committed when it comes of anything which can change the life of women, the life of people, it can be accepted and scaled up. Thank you so much for attention, and I do appreciate being here again.
Wow. Asante sana. Thank you. It's been an afternoon. We started from the UK, the University of Oxford. We learned about how to attract donors, how to be in the room and not just wait for people to mention your name in the room. And then when you face the person, we were taught how to pitch. Cindy, we are ready. Then we zeroed in on Kwale County. We heard about the good work being done by nurses. And we traveled by sea up to Kilifi, and in Malindi, excellent work. Then we took a short flight, and we landed in Meru. Were we together? Where the obstetricians told us how to use a structured way to monitor mothers and to reduce costs. Tuliona hiyo. But not only that, how to sharpen our soft skills. Were we together or I was alone? And then we zoomed out, because mothers are still dying. And we looked at the MPDSR. And we had Cameroon telling us that we are not making smart decisions. Did we hear that? And then we brought our star from Rwanda, because Rwanda has shown us what governance can do to reduce maternal mortality. He was very modest. He said, oh, we are struggling. We're at 149. Daktari, we are at 355 in Kenya. We kept quiet. Okay? And I know we'll be convening around you, clustering, to find out what we can do to reach that 149. So please stay with us today and tomorrow. We need answers. It's been an exciting afternoon. I'm sorry for making you feel hot the way I'm dressed. I'm feeling very hot. In the morning it was cold. I don't know what has happened. The sun is out. But I persevere. It's time for Q&A. Any pressing questions? Any pressing comments? Yes, please.
Yes, I want to thank the presenters, and I want to make a quick one to my colleague who presented ERAC. Are there exceptions to this alternative, or it's one shoe fits all?
Okay. Are there exceptions? And then there's another one. We take all the questions.
Yeah, mine is not a question, but I'm really impressed about the steps that have been taken in Rwanda, and especially the delivery of the blood using the drones. I'm just imagining not only the transportation that we have a challenge, but also even the availability of the product. So keep up the good work. We are hoping that one day in Kenya we can do even better than that.
Thank you. Prof. ABC.
Thank you. Rwanda, I'm happy to hear about the 4x4 strategy. You actually invited me to talk about it. We're yet to get there as Kenya, but we're trying with Ewene. We have the 5,000 people that have been introduced into the system by the president. I want to ask Kilifi and all of us here, our biggest headache when we look at the maternal newborn is the perinate. We're losing the babies and we're also losing them in transit and referral. Is it the ambulance that we use and the quality of ambulances for referral that is a problem? But since Kilifi presented, I want to pose it to them. Have you done anything in terms of a relook at what I oftenly call the box? It really isn't the ideal. I don't know whether we can learn lessons either from Rwanda or Cameroon, or we need to have a rethink about that referral.
Thank you. And the final first round, and then I take the second, Dr. Ryle.
So thank you very much for the very nice presentations. My first comment is to the Dr. Wanji, I think, the one who presented on the MPDSR. And I think the findings there mirror the reality in our country. But my question is it really the template that is the problem, or is it taking the actions forward beyond making the decisions? Because the reality here is that committees sit, they come up with action plans, but if you come next year, you know, there was this issue about the ambulance and nothing has happened about it. So I will appreciate more clarification on that. And then when it comes to the colleague from Rwanda, thank you very much for the strategic interventions that the government has taken. And I'm just wondering, since we know that when it comes to maternal and newborn health, the role of the midwife has really been brought to the fore, that, you know, since they can do most of the things, does Rwanda consider, you know, strengthening the midwifery force as a bigger strategy than perhaps, you know, I know it is important to have everybody, obstetrician, gynecologists, medical officers, but just to address this issue of maternal mortality. Thank you.
Okay. So if they could answer, and then we take the next round. We start with Rwanda, we go to Kilifi, and then Meru.
Let me start by the last one, very important. And yeah, you're right, because, you know, midwife currently, they're the ones who are taking care of mother and newborn during antenatal care, from low level to high level, from BMOG to CMOG. That is very critical. And as I said at the beginning, as in Rwanda in 2000, before even 2000, you know what happened in Rwanda? We had 2-3 midwives that time. I remember when I started university in 1998, there were not really midwives, 2 or 3. That was really terrible, which means we had the nurses at the health center and the hospital who are conducting all activity related to maternal. So that was really an issue. So the government of Rwanda, Ministry of Health and the Ministry of Education, they have prioritized really education for midwives. So we had to call midwives from outside to come and then help university to produce some of the midwives. But until now, we don't have enough midwives. We are still using midwives and the nurses, because midwives are not really sufficient. And as I said, among this strategy for 4x4 reforms, we consider midwives as well. And for information now, we have, I think, 2,000 midwives in the country. And yeah, so the other point I want to say, recently, I don't know if you know, through UNFPA, what we call smart advocacy, Maybe some of them have heard about it. So they are there to start supporting midwifery. And in Rwanda, it will be training hub for midwife through smart advocacy. And also, there's another approach, what we call midwifery mode of care. You have heard about it. In Rwanda also, we have started this through UNFPA Japaigo, supporting midwifery. And recently, through supporting from GET, they have hired chief midwifery at Ministry of Health. That's about the first time being that. So you understand now, we are already considering midwifery as a key driver for the country. We cannot forget them. Actually, midwifery, obstetrician, they are always together. Yeah, the other question from Professor Chiara, I didn't mention it, but something important. I said how in 2012 we had very limited number of obstetricians. I want to thank someone here who has been ready there for us, helping us to have currently OBGYN, Professor Chiara. She has been with us since that time, supporting us to have and to establish this expansion of midwifery, of OBGYN resident program-based hospital. So thank you again. So for your question, maybe here I will share my experience because I have been involved in this overseeing training. So one thing I have observed for losing mother and newborn during transit, first things, we didn't have people who are trained, ready to take care of newborn during transit, during referral, because all training we conducted were targeting only midwives who are in the services, and people who are working at the ambulances were not really taken into consideration. That's something first I can say. Second was the quality of ambulances as well. The quality of ambulances, we used to have ambulances by donation without the standard, without equipment included. And those other things was attitude of healthcare providers. We used to see really healthcare providers is in ambulance, but is sitting together with the driver, and the client is there. So what's your expectation? So if I give an example, that one in Rwanda, it's not possible since many years. Recently, we have changed ambulances. So now ambulances we have, they are already specialized. If it is newborn, we have ambulances with equipment for newborn, even CPAP inside. So we have those kind of ambulances. And now with this system of National Health Intelligence, we can control all related health. Our ambulances do have a GPS. If a driver drink, the car cannot start. Not possible. Yeah, that's what we have. And when we go to that center, National Center of Intelligence Center, we can map all ambulances. And also, the distribution is strategic. We have distributed ambulances located in different locations based on the regional. So that's why we hired people for that. Those ambulances have a different system. If a driver, alcohol, even one grasses, the car cannot start. So what I want to share, it's my experience, and we have seen really the difference since, I think, a couple of 2 years. Yeah, thank you.
Wow, thank you. Thank you so much. Next one, Kilifi, then Meru.
Thank you. Okay, for Kilifi, the issue of neonatal and perinatal mortality, yes, it's very high, but the biggest problem that you have is the first delay. Most of the times you see that the women will go to the facilities late after experiencing the danger signs. Like now, you might find a woman starting to have PPH and stays at home for 3 days before they go to the facility. And now when they go to the very facility, by the time now the ambulance goes for them, at times it's already very late. So we are dealing with the first delay in a way that in some areas, and especially in Malindi sub-county, the CHPs were not trained on Ramuka technical module. We identified it as a problem and we have started training them. We have already done the first Christ and we are continuing with it. Okay, I cannot say that sometimes you don't get delays in ambulances. Sometimes as a result of a high number of referrals, bearing in mind that you also have other referrals, not just obstetric referrals. And what the county is doing is they're in a system in improving the ambulances, at the same time increasing the number of the circulating ambulances to be able to deal with the high caseload of referrals in the county. Thank you.
Thank you very much. Meru?
Thank you for the question. I think the question was, for the ERAC protocol, are there exceptions or is it one size fits all? I don't even remember my favorite TV show. Anybody remembers? There's going to be a prize. You guys weren't listening? My favorite TV show? She was the first one. Okay, see me after this. The reason I say this is we've borrowed heavily from the aviation industry, and so we use checklists. And so for the ERAC, we actually have a checklist where all the elements have to be implemented. So that ERAC is applied to all patients. However, there are some instances where we apply different things. As I mentioned, the cornerstone of our ERAC protocol is that we use intrathecal morphine during the cesarean section, and that reduces the risk, the need for post-op post-op analgesics. And so the exception would be, for example, if you have a patient with HELP syndrome and low platelets, so that's a patient who would probably need to be under general anesthesia. So for those patients, given that they're not going to have the benefit of that, one adjunct that we use for those patients is we use a TAP block, which helps to reduce the opioid use after surgery. So we've sort of looked at all the typical scenarios, and so if a patient has this is what we do. But I think for us, what even inspired me to even use that approach is I believe that as human beings, we are fallible beings. You will forget. And if you look at the aviation industry, they've invested quite a lot in making sure that despite our human weaknesses, the system works. And so for us, that is why we have that system. I would invite in that, related to that, given that we are all about improving care, I would invite us maybe to look at, there's a book by Atul Gawande called The Checklist Manifesto. That book, I think, is a book that every person who deals with patients should read. As a parting shot, I know this wasn't asked, but I'll just mention this as a parting shot because this is something I'm passionate about. For those of us who are dealing with women, performing cesarean sections as midwives, as obstetricians, I would encourage us, please let us look at the evidence. We've actually have evidence that ERAC works. Patients are comfortable. They report better recovery. And in fact, not even us saying, I've had patients who we've performed C-sections and they've come for the next C-section after the next pregnancy. And a good number of them who've had the C-section done in our institution, some of them have even asked us, my experience was different from the last time. And lastly, as we've seen, it also saves, it's also cheaper because as I mentioned, 10.5 million is not small change over 4 years. And what we're able to do now with this is we sat down with the administration, given the tight fiscal space that we have, when we had the FIGO LDI project, and we found that one of the barriers was availability of tranexamic acid because of the cost, and we also use carboprost as a second-line nutrotonic, and so we're able to have that as a value proposition. And so currently, as we speak, we're able now to get those. So I think for those of us that are dealing with women performing cesarean sections, please let us look at that. Some patients ask, am I not going to be in pain and I'm not having any parenteral medication? And some of them, I even tell them, if you have any pain, don't even tell the nurses, just call me. And you come in the morning and there's no missed call, they haven't called you. But of course, you have to adapt it to the different patients. Otherwise, thank you very much for the organizers, and always a pleasure to have platforms to share the work that we do. You see, when I started this, I started it as a workforce improvement strategy. So in fact, I not even thought about it as research. So, but we've been collecting the data. So currently, we are now looking at the data to see how we can publish it. And one of the other things that we're looking at through fora that have interacted with other facilities is once we publish this data, we want to look at other facilities. We are discussion with other facilities in the region that do not have the ERAC protocol. Then we can also now longitudinally look at some of these outcomes. Then probably we can be able to see if there'd be difference. But for me, I mean, this is something that really excites me, because we've been able to see how translating evidence can lead to better outcomes. Patients are happy, and of course, the hospital administration is happy because it costs less. Otherwise, thank you very much. I thank you all.
Thank you. Thank you. I think the final is the gentleman beside you. Make it brief. And then I'll ask Tekla to pray for our tea.
I think I was just to ask him when he's just sitting beside me here.
We want to hear the question.
Okay. Partly you've answered it, but what I wanted to ask you is first to appreciate all the presenters. You've done an amazing job. But for you, your findings are very revolutionary. I just wanted to know if you went through the ethical review committee. And if somebody can come up with such a revolutionary idea and is allowed to do it without going through the ethical review commission. And the advantage of doing that is that now you need to publish again. Thank you.
Mm-hmm.
So we didn't do it, as I mentioned, this was just a workforce improvement strategy. And actually, in my view, what we did is we looked at the evidence. Actually, this is not something that we came up with. There's a wealth of evidence. There are Cochrane reviews that have talked about this. So we looked at the evidence, and actually what made me think about this was one patient when I went to the wards, and she was doubling up in pain and had her baby in the newborn unit. And I went and looked at her treatment sheet to find out, what's happening. And so when we looked at the evidence, that's when we applied this. So in terms of ethical, considerations, we didn't see any issues there, because we're actually just applying the evidence, actually what happens even in other parts of the world. And the surprising thing, when I even pored over the evidence, when I started thinking about publishing this, we found that there's very little evidence on ERAC, even especially in settings such as ours. But I think now that we've seen the impact that we have, probably there may be ethical considerations to consider, especially now when we identify maybe another facility that's going to act as a control. Yeah, thank you.
Thank you very much. To all presenters, to our guest speakers, thank you very much for sharing your gems of wisdom. As you can see, there are quite a number of questions, but our time does not permit us to stay here any longer. There is something else planned for after this. So I want us to all be upstanding as I request Tekla to give us our closing prayer. The something else after this is for the judges of the hackathon. So everyone else has earned their tea and the judges remain.
All right, I think we've really had a lot of knowledge augmentation today. We'll pray. Father, in the name of Jesus, we come before your presence this evening. Thanks because you've been with us since morning. Thanks because of been with us since the planning of this conference. We want to bless you because of the success for the first day. We bless you for all that we've gone through today, Lord. Lord, we are doing this because we are saving lives. We want to pray for your divine intervention even as we do all this, so that we can be able to have resources and what is needed to be able to implement.
We thank you even for the snack before us. We want to pray that you bless it. As we part to go home, to go to our destinations, we want to thank you because you're going to take care of us as we, even for the night. And tomorrow as we convene again, we want to trust you that you're going to enable us to do that. We pray trusting and believing in the name of the Father, the Son, and the Holy Spirit. And may the grace of our Lord Jesus Christ and the love of God and the fellowship of the Holy Spirit be with us now and forevermore. Amen.